of these two parameters, we quadruple the amount of output. Now, it's not unusual for a young, healthy athlete who is well trained to actually go out and get heart rates up closer to 200 beats per minute and volumes of closer to 200 milliliters or so per stroke volume, and therefore get into enormous cardiac outputs that are far in excess of an older person. We also have heart rate considerations. You probably have all seen the charts they have in exercise clubs and walls about your maximum heart rate. A young, healthy person can get up into normal, non-dangerous heart rates of 200 beats per minute, no problem. There are pathologic states called arrhythmias which get up to 300 beats a minute. Those are dangerous. We have to stop those from happening. But as we get older, our ability to get that rate up at all slowly decreases with time. It's almost a straight line. One of the rules of thumb for a safe cardiac rate, maximum rate, is to take the number 220 and subtract your age. So if you were 60 years old and you subtracted that from 220, you probably shouldn't be pushing your heart rate in exercise over 160, and probably should take 80% of that for safe exercise levels. That's what you see on the walls of all the gyms. That's where this comes from. Now, this doesn't say that a 60-year-old man or woman in good shape and good heart couldn't push up to 180 or 185. The heart might do it, and it might do it safely. These are just guidelines to keep you on the safe side. It probably is no advantage to conditioning to push beyond these kind of levels. Let's talk now about something you've all seen and actually may have been bewildered by many times, and that's the electrocardiogram. I don't know of many people who get beyond a very old age without having had one of these taken. It's called an EKG because it comes from the German word for cardiogram, sometimes called an ECG. And this is a picture of the electrical activity of the heart, and that's all it is. It's just a picture of the electrical changes that are going on during the heart cycle. Leads are placed all across the chest. Sometimes they're placed on the hands and the feet. And it's like taking a picture of something from different points of view. In other words, the two electrodes on your leg are seeing electrical impulses as they come off the heart, being transmitted through tissues and picked up in the legs. You can see them on the chest. You can see them in the hands. You can take this picture from wherever it gives you the best view. If you want to take a picture of my gradually enlarging bald spot, we'd be better off having a camera behind me. But right now, that's hidden. And we use the electrocardiograph, different leads to see different pictures. But essentially, all the pictures are giving us the same amount of electrical function, just viewed from a different place. The one I have up here on the screen is a very, very common lead. And this is one heartbeat. It starts off with a graph. The axis of this graph, what's called the x-axis, is time in seconds. And you can see here that this is less than 1 second, 0.8, from beginning to end. And so that means this patient would have a heart rate of about 70, normal resting heart rate. This is amplitude. Here's 0. And we can have negative and positive electrical charges, so that's what this is measuring. We have time and amplitude. In the very beginning, the first thing we see is something called the P wave, and these are just named after letters of the alphabet. They could have been X, Y, Z as well. Arbitrarily, we call this the P wave. This is the electrical picture of atrial depolarization, meaning the electrical impulse to contract the atrium has begun. It doesn't mean the atria has begun to contract. This happens about 1/10 of a second later, because first you have to have the impulse, and the muscle has to respond to it. So we're seeing atrial depolarization here, and the atrium contracting is probably going to happen somewhere in here. The next thing we see is called a QRS complex. We see a negative Q, big high potential spike to R, and then down below the baseline to S, and then it comes back. This marks the beginning of ventricular systole electrically. It's not the contraction yet, it is the electrical impulse, and of course the actual contraction will happen later. Why don't we see any electrical contraction in here for the atrium? This is when it's occurring, or we might see repolarization, where it's getting its electricity back again. The reason we don't see it, it's buried in this electricity. This is just so much electricity dominated by the ventricles that the little atria just gets buried in there and we don't see it. The next thing we look at is something called the T wave, right there. And that's when the ventricle is repolarizing. It's getting its electricity back again, getting ready for the next beat. So we see pretty much everything here for the ventricles. We don't see atrial recovery electrically because it's buried. And we measure these very carefully. The doctors, and now computers, measure these to fractions of a millisecond, and we look for normal length. There's a PR interval, the length of time between the beginning of the atrial contraction to the beginning of the ventricular contraction. We talked about heart block. What would happen in heart block? We'd have a prolonged PR interval because it would take longer for this impulse to get to the ventricle for it to contract. That's a diagnosis right there of heart block. You can actually have complete dissociation. If you have complete heart block, you'd see a bunch of P waves and you'd see a bunch of QRS complexes, and they wouldn't be coordinated. They'd be each doing their own thing. That's AV dissociation, atrial ventricular dissociation, something that can be rather serious. We can see big depressions in the Q wave, we can see big depressions in the S wave, and they all signal different types of pathology in the heart. You can see an elevation of the ST segment. In heart attacks, sometimes that happens early on. You can see the T wave flip upside down. That can be caused by other areas of the heart being damaged, or something called ischemia, meaning lack of blood flow. There's a whole diagnostic range of possibilities when you read an EKG. And EKG has been